Everyone. We'll go ahead and get started right on time. It's my pleasure to make the introductions today. My name is Paul Helfton. I'm the director of the Fairbanks Center for Medical Ethics, and we've been running this lecture series for the past 10 years. So I wanted to welcome you to the lecture series. This is being recorded and broadcasted, so I'd like to welcome our friends and colleagues from IU Health Ball Memorial and IU Health West Hospitals. Just a reminder to silence cell phones, pagers, etc. Dr. Gaffney has no relevant conflicts of interest to disclose. This lecture actually marks an idea that we had within the past year to honor Meg after her recent retirement, since she's one of my heroes, probably one of the heroes of several of you in the room. So this is our inaugural Dr. Margaret Gaffney Lecture on Humanism and Medicine. This has been in recognition of her outstanding work for many, many years as a professor, an ethicist, a teacher, a mentor to many of us. She spent, I would venture to say that you were one of the very first people around the School of Medicine doing ethics back in the days of the giants. So Margaret Meg Gaffney has a BA in English from Indiana University, Bloomington, and then went to the IU School of Medicine. She did her internship at Riley Hospital. Dr. Lemons says that he can remember her as an intern. Is that correct? And then completed a residency in dermatology also at IU, and then practiced here for nearly 30 years. She directed the Introduction to Clinical Medicine, which was a statewide course, and was the director of the Moral Reasoning and Ethical Judgment Competency in the IU School of Medicine. She chaired the Wishard, now Eskenazi, Hospital Ethics Committee for 15 years and served on the IU Health Ethics Committee and the Consultation Service for many years as well, and then retired in May of 2014. She remains a faculty investigator at the IU Center for Bioethics, where she served for many years, was an associate clinical professor, now emerita, of the Department of Medicine, and then has collaborated for many years on the Indiana University Conscience Project. So it's a great pleasure to welcome you back, Meg. We're delighted to have you.
Thank you all. Oh my, I'm having a little tachycardia here. Seeing so many people in this room who probably could and maybe should be the one doing this Humanism and Medicine lecture. Thank you all for coming. It is an honor to be here. And thank you especially on such a grim day. I guess it is December. We should get ready for this. I've been thinking a lot about this. In fact, I just have to say a little parenthetically, the last time I gave a Fairbanks lecture was on torture in the medical profession. Yeah, so, from one extreme to the other. We like to keep it diversified. Okay, I've been thinking a lot about humanism and medicine, and actually for years, and wondering what it means to be a human who's also trying to be a good doctor. This has actually been a pretty hard talk for me to organize, get my thoughts around. There are many stories, many ideas, and especially it seems that in the last few months, maybe in the last couple years, it seems to me we are bombarded with evidence of man's inhumanity to man. Unkindness abounds. And finally, as I said, it's also a challenge because I see lots of people who could be standing up here instead of myself. At any rate, here we are. And a couple of months ago, an event occurred that helped me start to orient and clarify my ideas. And today I offer sort of self-consciously a two-part examination or exploration of humanism, emphasizing first what I think is the really important need to be able to see who and what is before us, and then to be able to respond. And I'd like to explore the role of kindness as a primary response. So the event. As you know, for about 3 years, we in the world community have watched, sort of in mingled fascination and horror, this urgent surge of humanity fleeing homes all over the world. The causes primarily climate catastrophes like famine, flood, or fire, but especially it's war that drives the flight. And before the most recent violence of the last month or so and the debates about immigration here and abroad, it had become, at least for me, increasingly hard to comprehend the suffering involved of the hundreds of thousands of souls on the move, stateless, rootless, unwanted, nearly faceless. Compassion fatigue was setting in, and we mostly averted our gaze. Until a day, that is, in early September, when a tiny, smartly dressed, dark-haired boy washed up on a Turkish beach. You'll probably remember. And then, this suffering had a human face and a human name. Elan Kurdi. Zeynep, forgive me, I'm probably not pronouncing his name correctly. He was a Syrian Kurd who drowned along with his mother, his 5-year-old brother, and several others when their transport ship capsized. Elan died, and the world, at least for a moment, paused to see and to feel. So why am I starting with this? Because it seems to me that the central point of humanism and medicine is to encourage each of us to see the suffering human being before us, in the patient or in the stranger, hopefully when we still have time to respond. The volume, which is called A Dictionary of Philosophy, defines humanism like this: an intellectual and cultural movement which adopted an ideal of the full development of the individual, the ideal of a rich flourishing of individual potentiality. We as healers cannot engage with our patients or ourselves as humanists unless we see each other. Henry James, the great 19th century American novelist, wrote, quote, I love this quote, "The effort really to see and really to represent is no idle business in the face of the constant force that makes for muddlement." The philosopher Martha Nussbaum continues this line of thinking. She writes, "We live amid bewildering complexities. Obtuseness and refusal of vision are our besetting vices. Our highest and hardest task is to make ourselves people on whom, quote, nothing is lost." So, if or when we look in the hospital or in another setting, what do we see? Sometimes we, or at least I, have failed terribly to comprehend what I was witnessing. And one painfully remembered example occurred when I was a senior medical student here at Riley. I took care of Galen. He was a 17-year-old young man with severe cerebral palsy, wheelchair-bound since early childhood, nonverbal, spastic. He drooled pretty much constantly and had such severe kyphoscoliosis, I don't know if the medical humanities students know, so his spine was crooked sideways and also front to back. His twisted upper frame was affecting his heart and lung function, literally squeezing the breath he struggled for. He was admitted, understandably, for cardiac and pulmonary problems, and I cared for him for nearly 6 weeks. His parents were lovely and devoted. His mother was always here, and in those days, some of us will remember, Riley did not have a cafeteria, much less a Ronald McDonald House. Think about that. His mother stayed every night in a chair at his bedside. So I said he was nonverbal, but that did not mean that he did not communicate. His mom had made a communication board with colorful symbols and pictures and affixed it to a tray on the front of his wheelchair. And Galen would strain and point with fingers or nose or bent elbows, and his mom would understand what he meant and what he needed. But I confess I did not understand. For the first several days, I made rounds in a perfunctory way, sometimes even tried to avoid it, even though his mom was so kindly encouraging. Secretly, I thought it was kind of sad that she, his mother, had had to give up her life, as I saw it, giving up her life to take care of Galen, and that in some crucial way, it was a waste. I blush with shame now when I think of my judgmental attitude and my limited empathy. At that point, I had no beloved child. My dear daughter had not yet been born, and for this and many other reasons, I could not see who and what was present before me in the room. Over the next couple weeks, though, I did begin to get the hang of the communication board, and I started dropping by in quiet moments to say hello, and even in the rare times when his mom wasn't there, Galen and I talked. I began to see him more clearly, his intelligence and humor and his great courage. And one early morning when I came in, he looked more afflicted than usual, grayer, and his mother looked very worried. And then, while I was standing there, he just coded. It was an excellent code, as far as they go. The IVs were in and they worked. The senior anesthesia resident, Lynn Means, some of you will remember, took charge in the first minute or two. Drugs were given, CPR was done. and Galen was gone. It was a perfect code, except that my patient died. I could not believe it. At one time, I might have thought that this death was somehow for the best, as somebody tried to tell me, but on that morning, I did not. I felt such grief and loss and fled to sob alone in the stairwell. Because by that morning, I could see in Galen a living example of gallantry and integrity in the face of overwhelming struggle and affirmation of life. And in his mother, a model of abiding loving kindness, attachment, and devotion, not servitude as I had once thought, but love freely given. So, when we look, we may see a Galen, or a stranger, rootless, a refugee, or we may see a figure with crumbling teeth, ragged clothes, smelly skin, who lives under a bridge a few blocks from this great hospital. Probably everyone in this room has been face to face with a stranger holding a sign reading something like this: "Hungry, please help, God bless." We see these neighbors on nearly every downtown corner and in many spots around our campuses, and we struggle with our response. The senior medical students on the ethics elective last February engaged in several poignant conversations about many aspects of ethical lives in medicine. One such started with lavish praise for the heroic and compassionate sacrificial service of healthcare providers treating Ebola victims at great personal risk. Remember Ebola? Kent Brantley and others? And we went on discussing professional duties of care, and then one woman with anguished look and voice just broke in, and she said, quote, "I don't even know how to respond to the 3 or 4 street persons begging on the corners I cross every day just to get here. Should I give money, bring food or blankets, take them to the nearest fast food restaurant to use the bathroom and have a meal?" I do not know, and our class did not resolve this struggle. But recently I found, ironically, my own response in a journal entry I made last March while I was visiting Aaron in San Francisco. It starts, I don't even remember writing this. It starts, "I have rarely been so undone by the figure of the beggar. No other way to describe him. Cachectic, shriveled, arms outstretched. I thought, he cannot have long to live." And then he turned, and our eyes met. So then what do we do? In the face of this suffering, what is a good person to do? If we make eye contact and acknowledge our shared humanity, then what? And does it matter specifically or differently that we here in this room are healers? You see, there really could be a difficulty if we try to see the other. But you know all this already because you live this daily, and obviously there are numerous virtuous responses. I'm going to consider just a few of them with you and see what you think. So first I wonder, are we called out of our daily lives to be heroes or saints? This may be too much information, but when I was a really little girl growing up in a strict Catholic family, I wanted so much to be good. But I thought that was pretty hard, actually. I did love reading stories. If my sister were here, she could tell you. But I loved reading stories, especially about the good saints, and I thought I'd like to be one. Well, of course, that didn't work out. And then as I got a little older, I became more interested in heroes, and I decided I wanted to be one of those. Alas, that hasn't worked out either. But learning about the saints, and especially the heroes, was very important as I started the lifelong process of exploring 2 central questions. The 2 questions that I particularly have come up with that sort of frame my life. What am I to do in order to be a good person? And how am I to be? You know, the usual frames of conduct and character. I kept searching for what linked the lives of the holy and the valiant, and always it seemed it was the force of the connection to the other, to the needs, to the suffering, or to the peril. And then in late high school, I read Albert Camus' The Plague. It was for me then, and remains, one of the most profoundly illuminating works of moral imagination. For those of you who don't know the story, a bubonic plague is ravaging the Algerian town of Oran. The town gates are closed, citizens are cut off from their loved ones, bodies are piling up, literally, and each character chooses how to respond to this evil. 2 of the central figures are 2 men. One is the physician, Dr. Roux, and the other is a man named Taru, a somewhat mysterious man who's not been long in town, but who undertakes the organization of the the sanitation teams, disposal of bodies, disinfecting homes, very dangerous work. The bubonic plague would kill 2 out of 3 people. Both men are brave, resisting the plague as best they can according to their skills. And eventually, over the course of the plague, they become friends. One night, near the end of the novel, they're exhausted but not demoralized, and they share a few quiet moments assessing their situation. And then Theroux says casually, I love the way Camus says, he just throws this in casually, quote, "What interests me is learning how to become a saint." They both know this is a special kind of problem since Theroux doesn't actually believe in God. That's a separate issue. There's a pause. The doctor answers, quote, "Heroism and sanctity don't really appeal to me, I imagine. What interests me is being a man." And then Theroux, "Yes, we're both after the same thing, but I am less ambitious." It was stunning to me. And so finally, at age 17, I decided that my life's project was to try to become fully human, to learn how to do that, be human, well, to become a person on whom nothing is lost. Well, it turns out that this life in medicine has been the gift that has nourished and illuminated the humanism I sought to develop, share, and experience. So many stories. We call them histories when they have to do with our patients. The stories are heroic, heartbreaking, joyful, inspiring, and human. They're also stories of our colleagues, heroic, heartbreaking, compassionate, and human. I've learned through this privileged life of listening and presence to hear the stories and to see the heroes and the saints among us. And the connecting, responding thread among all of us, the one that makes the most sense to me, is loving kindness. In the end, as that song goes, kindness matters. Kindness may soothe the fearful, welcome the stranger, comfort the bereaved, counsel the doubtful, serve the suffering, deepen compassion. This brings me, you may be relieved to know, close to concluding, but I have one more story. This is one about one of our colleagues. She did not serve overseas in Kenya or Liberia. This excellent physician has devoted her entire working life to central Indianapolis, where she was working late one night in the Wishart ED when a young woman about 30 years old came in alone, desperately, desperately sick, and also dying of metastatic cancer. After a few hours, the patient's acute crisis had eased, and my friend, Dr. K, started the discharge conversation. But it soon became apparent that this young woman had no family or friends, no home, no place to go to, and that she was dying. Hospice without a home or funds was not an option, and the Abbey Hunt Bryce home had not yet been established. The patient had no options except the street until Dr. K took her hands and said, "You'll come home with me now." And she did. Dr. K took her home. Her husband and Dr. K and their 2 children cared for the woman in their home until she died a couple weeks later. I did not hear this story from my friend, and I do not think my friend would believe this heroic. I think she thought it was the only thing she could do, or rather, it was the only thing she could do. But I'm awed. Isolation, pain, and despair were answered by extraordinary human kindness. And once we start looking, I think we'll find that we can all tell many inspiring stories of patients and colleagues and students and friends. And I think we should tell them. They will be stories of unexpected random kindness of strangers and stories of the practiced kindness of professionals. They will help counter cynicism and demoralization, protect us from lapses in caring, in the way that reading about the valiant and the saintly may inspire or instruct. Sharing stories about kindness will, I believe, sort of rub off on us and help us actually become kinder. And finally, to that point, the New York Times recently republished author George Saunders' 2013 address to the graduating class at Syracuse University, in which he focused on the need for kindness and all the ways in which our world seeks to derail us from being and acting kindly. Some of you probably saw it. A very kind friend sent it to me, probably thought I needed it, and it is a wonderful piece. Saunders, whose actually 57th birthday is today, happy birthday, George, not that I know him, he's kind of a genius. He won, in the same year, he won a MacArthur Fellowship and also a Guggenheim Fellowship. Amazing. He wrote, quote, "What I regret most in my life are failures of kindness, the moments when another human being was there in front of me, suffering, and I responded sensibly, reservedly, mildly." He continues, quote, "Kindness is hard. Saunders thinks we are born with built-in confusions, as he calls them, that suggest to us that we're more important than others, independent from others, and also quite possibly immortal. In other words, we're not really sure we're going to die. We do not actually believe these things, but they often subconsciously get in the way of us behaving well, not to mention the concerns among many here in this room of being overworked, highly stressed, and overwhelmed by the needs of those we have promised to serve. We have to work our way together through these confusions to kindness. Like other virtues, we can and we must practice it. Saunders believes we actually grow kinder as we age. I don't know if I believe this or not. See what you think. His advice to all of us is to hurry up, get kinder. I love that. And when in doubt, quote, "Err in the direction of kindness." Isn't that great? "For then we shall have less to regret." I think that is good directional advice in healthcare, in love relationships, and in life. For me, even when I'm unsure how else to respond, it helps me smile at strangers on the street. Many others have written volumes on the power of kindness, but I'll close with Henry James again. As you may recall, we left him striving against muddlement, his own confusions. Henry wrote, quote, "3 things in human life are important. The first is to be kind. The second is to be kind, and the third is to be kind." It seems for Henry James, as well as for George Saunders and so many others, kindness is a beacon toward rich flourishing. Thank you all.
Question then.
Great.
So it's sort of a two-part question. The second part is, what did you learn about teaching or helping people to learn, medical students to learn kindness in the many years that you taught medical students? Sure. I have a two-part question. The second part of which is, what did you learn in your many years of teaching medical students about how to help them learn, or how did you learn to teach kindness? Is it teachable? Is it learnable? And the first part of the question is that in a time when medical student education has evolved rapidly in response to many, many pressures, and medical students, at the same time, our consciousness has been raised about the importance of the human qualities in medicine. We are burdening medical students with many other things that they now need to learn about healthcare economics, about quality improvement, et cetera.
Right.
And I just wonder how you reconcile those tensions in education.
Oh boy. Thank you, Dr. Helft. I have a couple of responses. The first is that I think I learned as much about kindness from my students and certainly from my colleagues as anything I would have been able to teach. I do think that I believe what Saunders said, and I really believe that we learn. It's like the old thing from what I learned in kindergarten. We learn about being kind from people being kind to us. We learn about service by seeing it in action. So on a more practical level, I would just like to say officially for the record is that this was the whole point of the Intro to Clinical Medicine first-year course, the patient as person. That was the point of that course, and that course is pretty much going away. I know there will be pieces of it, but that was the labor of love, and I think that the people for 20 years, it felt like the right thing to do. But you're right. Education has. I don't know how to. There's not enough hours in the day, not enough years of education, and then the whole thing about burdening medical students with this enormous debt, so that even if people and all the incentives are aligning in a different way, so now the electronic health record sometimes can be very helpful, sometimes can just be completely in the way of trying to be a good humanistic kind of physician. Being driven to see a primary care patient in 7 or 8 minutes. One thing I will just say, as I said when I retired, I am so grateful to the Department of Medicine and to dermatology. I was not under that kind of time pressure. That if I needed 20 or 30 minutes with my dermatology patient, I took it. And I loved it. I loved my life in medicine, and I think there are many people now who are struggling with that because they don't have the same sort of connection. See, I think it's all about connection. And in terms of teaching kindness, I think you have to have time, and you have to have the people who love what they do, and love being a teacher, and then it all works, I think. Other questions? Oh, Dr. Sachs.
Meg, thank you so much for a wonderful presentation. And I'm kind of struggling with thinking about ways, and maybe this is just building on Paul's question, of trying to build this into our daily lives. In some ways, I think we've become very effective at squeezing it out of the students and residents,
Right.
so that by the time that we have people in practice and on faculty, this is, in fact, one of the few opportunities I've had in a long time to actually stop and think about these sorts of things. People are so focused on things like grants and dollars and RVU generation. So do you have, you personally, I know, had to have had things like journaling and others. Do you have things that you could suggest to all of us that we try to carry forward, practical tips in our daily lives to both maintain for ourselves a focus on kindness and humanism and how to spread it, in addition to just saying, be more kind, like Saunders?
This question from one of the kindest physicians in the room. I don't know. I think one thing is to be in community with each other, to recognize what you just said and what Paul just said and what each of us struggles with, is that the work that we're doing is important, and it is hard, and we don't do it by ourselves. And that when you feel yourself being overly stressed, when I see in myself a tendency toward a lapse in caring attitude, I look to my friends. I see Greg Gramelsbacher back there, who kept me straight more than once, and to people who I know are kind and good. Maybe not all the time, but that's we all need help. So I would say find the people who you know will help you be the best you can be, the kindest and the best physician, father, teacher, friend. Stay with them, work with them. If you're really lucky, you get to live with them. And give the only other advice I would say is really listen. I think listening to me, in fact, I have this recurring image in my mind, I don't know where it comes from, of being, and it's always in a garden, and I'm always listening. I'm always sort of like this. And I don't know if I'm listening for the flowers to talk to me, which could be a problem. It's like I'm listening for something. And to me, the listening has been, I used a lot of imagery about seeing here, but it occurs to me that in my daily life, listening is at least as important. Other questions? I'd like to just throw one thing in. So I did retire officially last year, but I'm still doing actually quite a bit of teaching. But one of my joyful parts of the week is I'm a tutor at the Learning Center at North Central, where I work with Greg Gramelsbacher's wife, Mary Lou, who's a wonderful human being. And one of the things that I have been it has been another life experience for me. Many of the students are here from other countries, stress conditions. English is not their second, it may be their third or fourth language. And I'm supposed to be tutoring biology and earth science and zoology, and students can't read basic English. This is a challenge, and this took me a little while to figure out kind of where really the problem was, and it's obviously different for every young child. I tried to work in a story about some of my students who have just bowled me over. I have one student who I couldn't quite figure out how to do it in this particular talk, but I have one student from Burma, now Myanmar, who is 15, although she said immigration changed her date of birth when she came in 2 years ago, came into the U.S. I didn't think we did that anymore. I said, how old are you? And she goes, well, I'm supposed to be this, but actually they tell me it's January 1st, such and such. I go, oh, okay. So she's now 15 or maybe 16, depending, and she lived 12 years in a Thai refugee camp. Now think about that. 12 years. She barely remembers Burma. She didn't learn Thai because the Burmese community there, they were segregated. She said, you have to have money in order to eat. You have to have money in order to go to school. Yikes. And she comes every day at the same time, this bundle of energy, she's about this big, this bundle of energy, already talking, Miss, I need help with this. And we're Miss, everybody's Miss. It makes it easy, you know. Where's that other Miss? Which one do you mean? Oh, the one who usually sits over here. Anyway, so she's just another student who's from the Dominican Republic who it's a heartbreaking situation, keeps trying to reach her mother who never seems to be around. And she loves to read. Her English isn't very good, but she reads 2 books a week. It's just, you know, it's amazing. So anyway, I'm getting a whole different kind of education, and it has been a real privilege. So now when I look at the pictures of people fleeing homes, I have in my mind Teresa and Desnali and all these other students now who are so brave and working so hard. Yeah, Dr. Schneider.
So the previous questions have been about how to make medical students more humane. The previous questions have been about how to make medical students more humane. What are your thoughts about selection of students to enter medical school? And
okay, so this from the director of the Medical Humanities Program. Yes, Bill. Yes, I personally think that having a background in literature or philosophy or religious studies or ethics or history or peace studies, comparative literature, I think something non-science is invaluable to be a doctor, to be a healer, to be a nurse, I think it's actually important to be an educated person. That's just my bias. I was an English major. And actually the medical students sometimes would say when I would be correcting their histories, they go, this is not English class. And I go, actually, you know, you got a former English teacher, wrong person to say this to. And you are a graduate student and you will write in a literate way. Anyway, I was a little over the top sometimes, a little over the top. But it's not easy. I also cried every night for the first month of medical school. I had the bare minimum of undergraduate requirements. I said, I was already 23. I said, I'll give a 1 year. So I had no science as an undergrad, which I don't recommend this, actually, if there are pre-meds in the room. I think you ought to have a little bit of science. And then I graduated in English and religion, and then I worked for a year and a half for the Public Defender's Office. That's another education. And then I did a year of pre-med here at IUPUI, and it was just the minimum. And the first month especially, it was just awful. I thought, whoever thought this was a good idea? I'm going to fail. I think I got very close to failing my first biochem test. I nearly withdrew from medical school. And then my husband at the time said, wait a minute, I don't think you're stupid. I think maybe you just have to figure out a different way of studying. And that whole right brain, left brain thing, that's real. At least it was for me. You really do have to engage a different kind of learning. Anyway, I really didn't feel like I was a really good medical student. I mean, I passed everything successfully. And when I got to be a junior medical student on the first day on the wards, I knew I was home. I absolutely loved being with patients, sitting with patients. And because of certain life experiences, there were things that were easier for me than there were for other students. Both my parents died young. I don't wish that on anybody, but it did actually mean that there were certain things that I wasn't so afraid to go through. And I could also help some of my colleagues, most of whom who had no experience of loss. So this goes back to medical students. You know, you don't want young people to be ill or to lose loved ones. So most of our students come in healthy. Some have never even been to a funeral. And that's wonderful until we put them at the bedside of a dying patient and say, show some empathy. Stay, listen, don't be afraid, don't run away. That's pretty hard. That's pretty hard. That's another way that we as teachers can help, that we can help model that kind of the witness and the presence. That's our privilege to be there. But it takes courage to do that. Yeah.
Hi.
Hi.
Thank you. I have a question about going back to kindness. When you were speaking about kindness, I was very moved, and your stories were very beautiful. And I've often wanted myself to be able to be those people that are in your stories, these people that I would think of as heroes. But often when I'm faced with difficult situations, I really don't know how to reconcile how to be kind. What is the kindest thing you can do, especially when there's so many other things pulling you in so many different directions? Yeah. If we don't have the ability to do something as amazing as take a dying patient home, how do we know that it's kind enough? How do we know that our option or our decision is enough?
Oh, Amber, if I knew that, I'd be a saint, which we already know.
You
I'm
are.
not.
That's why I'm asking
you. We already know I'm not. So I don't know. That is the question, isn't it? That's still that no matter how. I mean, I think we look to our exemplars to see what is possible. At least, I mean, even to the really holy exemplars, to see what is really possible for one human being in community with another. For what is possible for each of us, I think, I do think Saunders is right in one way. There are some things that become easier as we get older. I'm less afraid now to be silly or to try something. I have less to lose in a way. So in that way, if being silly or trying something new is actually the kinder way of being, then that part is getting easier. But I don't know how to answer the rest of your question. I mean, if other people do, I wish you would. I mean, like I said, there are many people in this room who I can look and see and remember extraordinary examples from you of your kindness, of your goodness. So if anybody has ideas, please. Yeah, Joy.
But I guess one thing I would say when confronted with a patient, a difficult situation, to do something kind is better than to do nothing kind. Mm-hmm. You know, is it enough? Often it's not enough. Mm-hmm. But to make a decision to do something mm-hmm. in that direction is better than to do nothing in that direction. Mm-hmm. So...
And that's where that story from the senior elective came in, because that's what we were really struggling with, is how do you know first of all, if what you're doing is the best thing to do, but how do you live with yourself if you don't do anything? There is a process. And the other thing, you don't have to do it by yourself. And for those of us who are healthcare providers in this room, that's this real risk, I think, of feeling so overwhelmed by these needs that we cannot possibly completely answer, is a sadness and a deep regret, and over time can in fact lead to something worse like demoralization. So.
For me, it's been my faith that has been the strongest element. And I think that I do what I move to do in my spirit, and being open and being just fully present with a patient and hearing them and being patient with that person.
Lucia.
So thanks very much for the talk. I want you to reflect on and offer any advice on sharing kindness with each other. We're confronted with patients, and I think for many of us, going the extra mile or an inch or whatever distance you want is one thing. But I think the thing that I see lacking is showing kindness to our colleagues. And I wonder if you would reflect on that.
So did everyone hear? How do we show more kindness to each other? Boy, so there's one thing we can do. And I think this goes to Greg's comment many minutes ago too. I think we can establish places specifically like this, or opportunities to reflect and to share. So it can be intentional that way. The other thing is just to actually, again, to when somebody, instead of just, it's like this all, how are you fine? Well, a lot of times we're not really fine, but we don't really want to share, or we feel like if we tried to share, it would fall on deaf ears, or the person would be going, I got a grant meeting, I got to go, and in fact, we all live these very busy lives. I don't, again, Lucia, I think as a practice to, I think, take a breath, take a pause, really look at the person who's before you and try to listen with not just your ears, but your heart, and see what might be going on. I think the other thing is to recognize at sort of an organizational level the kind of level of stress and areas of concern that we have, and put into place some structural response to that, or a time to allow response to that. I don't know. Schedule a massage. Dr. Lemons.
Yeah, thanks, Meg, for that awesome talk.
Thank you.
I was just thinking two things. One was so the demoralization or the drainage part. I think you are a model that kindness is so nourishing. It may be depleting in terms of energy and fatigue, but over time, I think you've taught us as well as anyone that it's enriching. That's where the depth of joy comes from, I think.
Thank you.
But on the other side, I was thinking, what are your thoughts? So, how much is enough?
Yeah.
And oftentimes when I'm talking to pre-med students or college students or high school kids who are thinking about pediatrics, and often they will say, oh, I don't think I could do that. I care too much. And can you care too much?
Well, I remember I said that actually when I was a junior or a senior medical student to a man who was a pathologist at the VA, of all things. Isn't this funny? I can't remember breakfast yesterday, but I remember this. He was a kind man and a really interesting guy, and he was from maybe Turkey. I'm not sure. But he was not from the U.S., had trained in another country, but had lived in the U.S. for many years, and was a pathologist at the VA. And I remember he asked me what I was thinking about, and I said, well, I really love pediatrics. I really think that's what I want to do, but I don't know. Those kids will be so sick. I don't know if I want to, be hurting them. I have to start IVs on them. And this is after my experience at Riley, at least one or 2 months of it. And he said, he just looked at me and he goes, well, that's just the reason you should be doing it. And I said, pardon me? And he didn't mean the hurting part, I don't think. No, he meant that a person who is concerned, so concerned actually for the welfare of the child, it could be for the welfare of the elderly, for the dying, for the woman, for the man, whatever, in fact is the person who ought to be doing the care, whatever that takes, whatever kind of interaction that was. My personal feeling is I don't think you can care too much. I do think in people my age, there aren't too many in the room, but when we were in medical school, we were basically told, this whole thing about equanimity, that you don't get involved, you don't, this sort of moral emotional responsiveness is not such a good deal. And I was trying to sort of get at that too. If you actually look, if you do what I'm suggesting and actually look and see the human being before you, then you cannot help but have a moral emotional response. This is not covered in the bioethics principles. Let me just tell you. They don't talk about this. What am I to do with grief when a patient dies, like Galen? What am I to do with guilt when I know that what I just did may have landed this person in a worse situation, God forbid, loss of life or limb? Those kind of, what happens if you make a mistake? How do you repair something that cannot be repaired? And then if you can't, how do you forgive yourself and go on? Can you? So those are some of my thoughts. I think there's a danger. I think clearly there are professional boundaries, and I think back to Lucia's point about trying to be kind to each other, that this is when we look and we see somebody who's struggling, then literally put your arms out, put your hands out, ask to go for a cup of coffee or tea or a walk, or go to the labyrinth or whatever it is or sit in a quiet room and just say, tell me. And it usually doesn't take very long. And similarly, as Joyce said, with patients, I was seeing patients on one side of Forest Manor, and the nurse from the medicine side said, could you just look at this guy's ulcer on his leg? Something doesn't look very good. And his doctor wasn't there. And I said, sure. So I went and I looked and I said, hello, Mr. So-and-so. Tell me about your leg. And he goes, my wife died. Okay. So you sit down and you say, tell me. It's not what I thought was going to happen. But that's where I think really the joy, that's where the service, that's where the connection, that's the possibility in healthcare, in medicine, in ministry, in teaching. I think this is what we're about. And if you don't have that, if I wasn't able to do that, I wouldn't have been able to be a doctor. It wouldn't have made any sense. I'm not answering these questions very well, but anyway. Yes, please.
Sometimes when studying biology or studying chemistry, it's hard to see the person behind, see the person. So would you say your background in English and writing and reading has helped you understand the emotions of the person?
Oh yes, it certainly did. So that was a great question. And yeah, sometimes you kind of think, why am I studying biochemistry? And how much did I really use biochemistry? Now, if there's a biochemist in the room, I apologize. I think there are lots of reasons that we study chemistry, biochemistry, et cetera, and they have to do with discipline and background knowledge and other stuff that you can bring to bear later on. And yes, sometimes it's pretty hard to remember keep your eyes on the prize, as Greg Ramelsbacher would say, or see the long game, or whatever your metaphor is. That the goal at the end of all this is to take care of suffering human beings. And some days it's easier to see that when you're studying your chemistry than others. It helps really to do, I personally think it helps to do some volunteering, some service, so that you actually have a better idea of this is actually where I'm going, or find a friend who's a couple years ahead of you in school, or go to the student outreach clinic, or whatever. I think there are all kinds of options. It doesn't even have to be in healthcare, but if you're really struggling with why am I doing science, that might be helpful. Yeah, but you're not alone. Every pre-med student has done that.
So I think sometimes a great kindness can be being a supporting actor in someone else's kindness. And so this speaks to what Lucia mentioned and others in the kindness that we show to our colleagues. Maybe simply, I'm going to do something for you now so that you can provide the kindness that you desperately want to provide to your patient or to another staff member that I don't know well. So looking for those opportunities to do very small things that allow them to have the opportunity to fulfill that bigger kindness is a really nice thing to watch for as well.
Thank you. That's a wonderful, wonderful point. Thank you. Oh.
I'm sitting here thinking about the discipline of nursing and the research that's been done in how a nurse progresses from advanced beginner to expert. And she doesn't reach expert till she goes through the stage to become more than competent at her skills, but to see the patient at the proficient level. And she becomes expert when she can make moral judgments related to the suffering and needs of that patient. So if you've never read any of that nursing literature, I think it would be interesting for all disciplines to look at how do we develop from our advanced beginner to expert, and where do we begin to see the patient. And I think that might lend some insight to how you help med students and people moving through another discipline.
Thank you. Thank you. Great recommendation. Okay, thank you so much.